Hey everybody! Before we jump into the next episode of the show, I did a thing. I wrote my memoir. It is 61 years of my life condensed down into 162 pages. The book tells everything about my life. It talks about my childhood. It talks about what it was like to grow up as a trans youth in an evangelical family. It talks about my love life and my sporting life. The book is available on Amazon. If you go there and you type in Kelly's Quest, The Journey to Become My True Self, you will find the book. Anything you can do to help me on my journey and this quest would be greatly appreciated. Thank you. Hello everyone. Welcome to Kelly's Quest. Today I am so fortunate to be here with Dr. Carl Streed, and we are going to be discussing research in transgender healthcare from many different angles. And I'm so fortunate to have you as a guest on the show because I know, Dr. Streed, that you have been helping the community and doing research on our community in a way that other people are looking for answers that aren't out there. So you're out there trying to create the answers for other professionals that they can help us. So thank you so much for doing that, because I know so many times I go to my doctor, my endocrinologist, and he'll be like, well, we don't have the research yet, but here's what we think is the best actions for you, especially with me now being more of a senior trans person. You know, I'm not going to say my age, but I've been on this planet a minute, and apparently as a trans person, as I age, my healthcare needs change, just like everybody else's does, and they're not quite sure. So I really do appreciate that you're trying to get these answers out there for people.
I appreciate it. It's a long process, to say the least.
It is a long process, and I'm assuming that this process also takes time.
Yes.
As far as it's long to get the process started.
Right.
And then you can't just bring in a trans person for 1 week and be like, the research is done, we've got her answer.
Yeah, no, absolutely. The work that I try to aspire to is work with or even led by trans folks. Like, all of my research questions are based on the actual experience of my patients. The work is done with trans folks in terms of actually conducting the research, and then even the dissemination itself has to be community informed and community led, ideally. We needed people like you 100 years ago as trans people were. Well, we've been around forever. But modern medicine is now coming along, and things are happening to help us become a more authentic self. True. Although I would say, in terms of like the history of medicine perspective, there have been people who've done this kind of work over a century ago. Magnus Hirschfeld is a prime example that people have been more aware of lately, having done their work in Germany back in the early 1900s, and similarly worked with community, made sure community was affirmed, and the research questions were informed by those folks.
What happened to his research?
It's a leading question. Unfortunately, much of Dr. Hirschfeld's and his colleagues' work was lost because of book burnings by Nazi Germany. Is probably arguably considered one of the first book burnings at that time.
It seems like because there's so few trans people, we're the easiest scapegoat to go after. And the problems of the world are caused by these trans people. And trans people aren't perfect. I'm going to just put that out there right now. They're just like there's every kind of human on the planet. There's every kind of trans people. There's trans people that are thriving. There's trans people that are struggling. There's trans people that are making morally questionable decisions. Trans
people are people.
Yes.
People are people. I think that's what people generally need to recognize, is that trans folks are allowed to make the same decisions as everybody else.
And we sometimes make good ones.
Yes.
Yes. So you said that your emphasis in your primary study has been in trans research. How did you get to that path? And that's a journey that very few people, I would imagine, take.
There's the long way of describing it. I'll try to keep it a little bit abbreviated. There is the usual, there's the what is my CV? So I initially did my training in biological chemistry, University of Chicago. Thought I was going to do a PhD in trying to understand Alzheimer's disease. I was very fascinated about proteins and the effects on certain conditions.
Took some time, realized I really don't like doing bench research, and started working after undergrad at Howard Brown, which is like Fenway in Boston. So an largest LGBTQ health center in the Midwest. And first started volunteering my time at their Broadway Youth Center, getting to meet homeless LGBTQ youth, meeting them where they're at, providing services and so forth. And eventually started doing research with Howard Brown and became their research manager for a brief period of time on a number of studies, some of which naturally brought in trans folks. And that's where I probably really got to have longer conversations with people and understand their lives, understand what they wanted to hear from researchers and what they wanted to get from research. And all of that kind of merged together with a number of other experiences for me to eventually go back to school and study medicine. Went to Johns Hopkins. Johns Hopkins has a mixed history around trans issues.
Yes.
Doing much better lately, but we definitely understand there are some people in the past who have caused issues for trans folks. We don't need to dwell on that. But I would say during my time there, I definitely found myself being one of few people talking about broadly LGBTQ health issues and the need to train up physicians and so forth. And so got very involved in a number of organizations, the American Medical Student Association, the American Medical Association, GLAMA, historically known as the Gay and Lesbian Medical Association, but it's so much more than gay, lesbian, or medical at this point.
Okay.
And these are all areas where I got a lot more experience and broadened my network. I wasn't the only person thinking about these topics. I wasn't the only one trying to address broadly LGBTQ stuff, and particularly trans health. And then eventually was fortunate to get into internal medicine residency. So I'm an internal medicine trained physician with a focus on primary care, naturally, and did more training in LGBTQ policy, and then eventually found that I desire for policy to be evidence-based. We definitely are living in an evidence negative policy environment right now, which is unfortunate. But that led me to actually moving up to Boston and doing a fellowship here at Harvard Medical School, as well as the Harvard T.H. Chan School of Public Health. I wanted to get those research chops to be able to answer some of these questions my patients had and make sure that that got involved and wrapped into policy work. That's the long education story, that's the long training story. And I alluded to earlier that all of my research questions are based on very specific patient experiences.
Right.
I can think of a time during residency when one of my senior attendings was like, I have this patient who is starting hormone therapy later in life. They have already certain health conditions with regards to cardiovascular focus. What's going on? What can I do? And at that point, I was already known, at least within Hopkins, as one of the people thinking about this, even though I was still a trainee. And so I was like, well, I don't know either, and I don't think the research knows either, so let's start looking at this. And that was over a decade ago in terms of just starting to think about cardiovascular health in trans folks. So.
And that is so important, because I know with my endocrinologist, that's one of the main concerns is deep vein thrombosis, things like that, as I'm aging.
Exactly.
And he's working with me, do we taper you off of your estrogen? Because cis women are postmenopausal at your age. And they're slowly learning that maybe some of those women also might need some estrogen to help them. And he's been fantastic with listening to me and working with me on my needs. He's like, look, the worst thing we can do is just cold turkey stop you in gender dysphoria. Get triggered immediately. And I like to think that somewhere he got some training to know that we can't just stop you cold turkey. That's not going to help anybody.
Right.
And I feel like that as our population, what's happening, I feel like also is just like there used to, quote unquote, not be many left-handed people until it wasn't taboo to be left-handed, and then all the left-handed people were like, okay, I'm left-handed.
Right.
And I feel like the same thing is happening with the trans community. Now that this taboo has been lifted off of it, more of us are coming to medical professionals saying, I need this assistance. And all of a sudden they're like, we don't know what to do because there's not this research that's out there.
Absolutely.
So I really do appreciate that you're taking this research on, especially in our times right now, because there are people that do not want you to do any research.
No, that's very true. No, and for what it's worth, I'm one of many folks who are doing this, who've been thinking about this for a while. I'm standing on the shoulders of many other leaders in this space, and making sure that we also are not taking up too much space. Again, I think there's always caution when it's always cisgender folks like myself doing the work. We want to try and make sure that trans folks who are interested in getting the skills and becoming leaders in the space are able to be fostered and mentored in that way. I always joke in all of the early LGBTQ work that I had done, we always said like our goal is to put ourselves out of business. My goal is to not be the person that people first think of when it comes to like transgender cardiovascular health issues. There are many folks who are doing that work.
It's fascinating you say that. I work with traumatized teenagers, middle school. I'm a middle school teacher, and I work in a program with students that are traumatized. Something has happened in their life and they can't function in their school anymore, so they come to my program for 45 days. And our goal is for there not to be a need for our program.
Exactly, yes.
And it's kind of the same thing, but in your sense, you're wanting there to be so many people that
Correct.
can answer that question.
Absolutely. I need more people to think about the question differently. Like I definitely know I come with my own biases. As a physician, I'm looking at this very much from the lens of a medical professional and medical interventions, when I think we need to try to broaden that to like public health interventions. What can we do to make sure people don't even have to come to the doctor with these conditions?
That's true. I work with a nurse practitioner in Lowell, who I did an interview with, that is trying to do that very thing. She's got a community health center focusing primarily on queer people. And her goal is to create community with this, because I feel like a lot of times we don't intermingle with their own selves. Like there's not a lot of, like it's hard for trans people to meet other trans people and go out and just hang out and have a good time, or go to a ball game, or go gardening or whatever. And she's working to create that community, and it sounds like that community helps your health. It just does. Yes. So I'm glad.
Even for introverts like myself, the community is important, it's helpful.
It is. And you were talking earlier about you're hoping that there's like more trans people that get into the medical profession that can bring their own thoughts and concepts to this question and this research. Right now in the medical profession, in teaching schools, like there's a teaching hospital at the University of Tennessee that is there, and I can't imagine that they're doing any research on trans health care. I know Vanderbilt University in Tennessee was doing some, and they're kind of like, we're a little bit nervous now.
Yeah, they're definitely targeted more from a political perspective. I think it's important to recognize LGBTQ broadly and trans specifically work happens almost anywhere there are people who are interested and want to be actually supportive. And I personally try to check my own biases coming from the North Midwest. There's a lot of work going on in the South that people don't realize. Like University of Alabama has actually been doing a lot of LGBTQ cardiovascular health stuff, including trans-specific work for a while through a longitudinal study.
I did not know that.
Yeah,
that is fantastic
It's remarkable,
news.
Yeah. And a number of leaders, like Louisville, Kentucky, has actually been leading around medical education on these topics as well. So, and then of course there's always Emory and a few folks in Florida and such that have been doing this for a long time. So I always like to, again, check my own biases, but also remind people the South is figuring it out for themselves as well.
And it's important, I mean, because that's where a lot of the pushback against the trans community is happening, are in these states where there's already an easier inroad to cause that kind of disruption for our community. But that's also where people learn how to push back. Because they're right there in the middle of it. And I know that there's a Dr. Marissa Richmond that is a historian, a trans woman who's a historian who is, anytime I don't know something about the history of the trans community, I reach out to her as a friend and say, hey, what's going on? And she's like,
let me tell you.
Let me tell you. And so, yes, you're right. And thank you for pointing that out, because, I do have my biases because I did leave Tennessee because I am trans. That's why I left, was because I couldn't find work as a teacher in Tennessee. They're lost because I'm an excellent teacher, I feel like. But at the same time, it does seem like that where the pressure is being exerted the most is where people learn the most how to push back against that pressure.
Absolutely. I'm not asking for politicians to make life harder, but it's one of those things, it's the adage of adversity breeds creativity. People are finding ways to make things work.
Thank goodness. So let's say a person is watching this and like, I want to go into the medical profession as a trans person and help trans people with their cardiovascular health care or endocrinology or anything like that. Are they going to get a training that meets the expectations that they're hoping for, or is that training being created as we speak?
It's a little bit of both. This is one of the frustrations of medical education on LGBTQ health, and particularly trans health in general, is that it still depends on where you go for training. Some places are doing it really well. Some folks are really leading in how they are training medical students and then residents and fellows on these topics. And others are letting it happen passively because some faculty are championing it, but not necessarily the institution. And then, of course, there are places that are just not offering that at all. And this is actually some work that I've done where we surveyed all the medical schools in the US and Canada and saw who was actually training or providing any hours of education on LGBTQ and specific trans topics. And there has been improvement over the past like 10, 15 years, but it's still abysmal in terms of the amount of hours compared to everything else. So a trans person who wants to go into medicine right now could get an excellent education around trans health specific issues and can choose any field that they want and still do trans related work and get training on that. But the number of places that I can say that they would get that and get it well is still a small number of places. It's no guarantee that any medical school you go to will you receive this education.
So do your research before you pick your school, depending on which is for anybody going into university.
Absolutely. And I think it's also important to recognize you wouldn't be the only trans person in medicine. There are plenty of trans physicians and surgeons out there. Certainly want more, but I think I always try to remind people you are not the only person and you're not the first person, which is good. That means you can learn from people ahead of you, learn from their success and their mistakes, and try and find a way to navigate a path that makes sense for you. And on that, I just would always want to make a push for you are not required to go into trans medicine just because you are trans in medicine. I think people feel that pressure to always automatically have to serve their community. By virtue of you being a clinician, is already serving the community. I don't want people to feel like they have to know, if they want to be a surgeon, oh, well, I have to do plastic surgery and I can only do facial feminization work. I'm like, no, you can do whatever you want. And that's going to be a big win for you and the community.
Especially now, because healthcare providers are needed.
Across the board. Particularly in primary care, if I may put that plug in.
Okay, put the plug in. And why do you think that is? Let's just go ahead. Why do you think in primary care there is a greater need right now? Has something been happening in the background? Or
this is a larger health policy conversation, but I would say we continue to have fewer people choosing to go into primary care specialties, so pediatrics, adolescent care, primary care, family medicine, and so forth. Those continue to be a lower number of graduates from medical schools. And it's hard to be in that profession in the US. It is a lower compensated profession compared to other specialties. And there is a lot more work and regulation sometimes around that. That being said, I really enjoy it. I get to know my patients from young adult all the way through the rest of their life and get to see them thrive, help them get through certain things, identify the goals that are important to them and work with them. But I know that's not easy and that's not always for everyone. But I would also say, again, putting in a plug for our profession, we're one of the few professions that has research showing that the more primary care doctors you have in a community, the healthier the community is as a result. So you are making a difference at a population level by joining the profession.
I feel like what's happening is you're talking about continuity of care.
Yes.
That's very challenging right now. Like, since I've moved to Massachusetts, I've had 2 primary care physicians, 3 endocrinologists, a brand new dermatologist. Like, all of my doctors are retiring or moving. So continuity of care is a challenge just because of life in general. Like, you know, people want to retire. You don't want to have to work till you're 80, I'm assuming, as a primary care physician. You might, that might be your dream, but
I mean, there's something to be said for competency too. At some point, it's going to be harder for me to do the work, and I should really take a step back and make sure there's room for the next generation. But you're absolutely right. The continuity of care thing, you're talking about just the general attrition of people from these professions. With fewer people coming in, and we actually have this large number of people who are getting ready to retire, we're going to continue to see a gap in the amount of physicians we need to do this work. Clinicians broadly, including MPs and PAs as well. But I would also bring up this notion that continuity of care has often been dictated by insurance companies and other larger policies. And the number of times I've had patients being like, not to toot my own horn, but like, I love you as a primary care doctor, but my insurance plan doesn't include you anymore. So now I have to help them find another person. And so sometimes continuity of care isn't just the natural progression of people in the profession, there are policy components that are affecting it.
Insurance, when I first began my journey of authenticity, my primary care physician, for insurance to cover anything, they had to word very, very carefully what health care I was being provided so that my insurance would cover it, so everything wouldn't be out of pocket. And I would have
I was at a place in life, I was fortunate enough to where I could afford to pay out of pocket for a lot of these things. But it seems like as we move ahead, insurance said, yes, this is actually saving lives.
Yes.
This care is saving lives. This, and it can be in a lot of different things, not just trans healthcare. This is just healthcare in general. This is saving lives. And then all of a sudden there's this pushback a little bit, and they're like, maybe we shouldn't be providing this anymore.
Yeah, it's, I would say the insurance companies typically, and this is one of those things, the people in insurance companies typically want to do well. I think it's important to recognize sometimes insurance companies, we forget that there are actually people who are trying to change the system and do the right thing. Insurance companies, though, at least in our healthcare system, I think are always looking to save a buck and pass it on to their shareholders. That's my take on the healthcare system in the U.S. as a business model and in a capitalist perspective. But there's this notion that insurance companies understood based on the research, based on expert opinion, based on standards of care and so forth, that this care needs to be covered and that there are benefits to providing this care broadly for trans people in particular, but I would argue that there's gender affirming care for cisgender folks as well, and we cover that as well. So we should be covering it for everyone. And when we do that, you're right, we do see an improvement in quality of life. We see a decrease in mental health concerns or conditions, or at least the severity of those in a lot of situations. And insurance companies want to do that because happier people, healthier people live longer, cost less to them, which again, bottom dollar for them. But when you're right, when they see this political pushback, when that political pushback starts threatening their finances, they're going to be the first to sometimes pull back on care, even though there's no legal requirement that they do so. You and I had talked about this before, which during one of our panels that we were on. When somebody was asking, like, "Oh, what's the issue with regards to adult care? We know what's going on for young adult care and pediatric care and so forth in terms of states trying to regulate that, the federal government trying to regulate that." And I can honestly say it's really not being exactly regulated by the federal government or any states at the adult level, but the insurance companies sure are the ones who are causing a lot of grief because they don't want to have the political fight.
Right, and I know that their current administration that just came out yesterday with a new Medicaid stipulation that you can't help this community. And it's going to end up costing more money.
Oh yeah.
It absolutely will cost more money because I know that before I affirmed my authentic self, I was a hot mess. Let's just be blunt. The audience, they know I was a hot mess. They are aware that I was a hot mess. I affirmed my authentic self. I was still a hot mess for a little while, but I got the professional, medical, mental health care that I needed, and now I consider myself thriving, and I consider myself to be less of a financial impact on our healthcare system now. Like when I go to the doctor now, it's because I need a doctor. Like it's because I've not done anything dumb that caused me to need that doctor.
Exactly. I mean, healthy people do well, and healthy people, and from a business perspective, healthy people are more productive, and there are less issues at a system level. So I think the problem is, as you mentioned earlier, the government and certain political forces are targeting a particularly marginalized and minoritized group because they don't exactly have a significant degree of political power to fight back, and they're just using trans folks as a scapegoat. And that is just going to cause more harm. It's going to end up costing not only trans lives, it's going to be costing family issues as well for trans people, the people who love them as well. It's going to be causing issues in the community overall because if you're pulling away resources from trans folks, you're going to have a bleed over effect that's affecting everyone. This threat of taking away dollars from hospitals that provide pediatric care, that's going to affect care for all pediatric patients. So what's happening right now is really going to be deleterious for everyone.
The healthcare profession is so important for our community. Like, it's not one of those things that we can do without. Like, I've got a doctor's appointment coming up this Friday. The paperwork asks me all kinds of questions. Do I tell them that I'm trans in this because I'm not completely sure about how they're going to react to this information? So I'm now having to think, and this information is probably important to them that they would need to know because it's part of who Kelly Schutzberg is. But I'm leery because that's one more
institution
Yep.
that now has this information about me,
Yeah.
and I don't know how that's going to impact is this doctor going to be like, I'm done
Yeah.
with you? I don't think that's going to happen.
Yeah.
I've got absolute faith that it's not going to happen, but I can't be 100% sure.
Yeah, what you're describing is a lot of what I try to tell my colleagues and when I give talks to other health professionals, this notion of people are afraid of the medical profession for good reason. We have done bad before, and we continue to have issues with discrimination against trans people, against a number of groups when they seek care, which is really disappointing because we are a caring profession. We should be caring for everyone, and we should be making sure it's a welcoming environment. But this idea that, to your point about what information do I share, again, I'm biased from a research perspective. I want as much information about my patients as possible to understand broadly what's going on at a community level. And again, as a primary care doctor, I want to know everything that's going on for my patient because that's going to help inform what decisions I need to make as a clinician, what decisions they need to make with us in conversation about their goals long term. That being said, I'm always like, I respect my patients for putting down what they feel they need to feel safe. It's my goal to earn their trust and ideally get a more open conversation about really what's going on, what data makes the most sense. And I do encourage patients when I get these kind of questions for, like in your situation, when they go see another doctor, I always say, put down what you need to right now and have an open conversation with them if you feel ideally if you have the option to see another doctor just in case. But I'm like, you need to trust your doctor. You need to trust your clinicians.
Yep.
And to do that, sometimes that means you need to tell them everything about you and see what their reaction is and see how what information they can provide you and make a decision from there. With my patients, the first time I meet them, I'm always like, this is your chance to see if we're a fit. It's my job to provide you certain degrees of care and certain types of things. I ask of you to share information with me so that I can make those informed decisions with you. And if I'm not the right person, I'll help you find another person.
And I want to backtrack a little bit, that you are absolutely right, that women and black women's health care has already been under
Yes.
the gun.
Yeah.
You're absolutely right about that.
Yep.
And financially, Medicare and Medicaid and health insurance companies, they're watching all of this
Yes.
to see, okay, what's happening? What do we do?
Right.
And I feel like that for my community, and when I say my community, I'm actually speaking for Kelly Schutzberg. I can't speak for any other trans person on this planet because
Right.
I'm not any other trans person on this planet. I am me.
Yep.
And I know that, like, for me to go to my doctor that I'm going to on Friday, I contacted my endocrinologist and let them know, because they do know the whole ball of wax
Yep.
about me. So I'm like, I'm going to go to this person. Here's why I'm going.
Right.
Do you have any advice for me? So I've learned to be incredibly proactive about my health now too. And I feel like that's a gift or a talent that I lacked at the beginning of this journey, and maybe a lot of people lack it.
Yes, it's a skill. It's actually it's kind of funny. I feel like this week I was just talking to my husband where I'm just like, I remember in high school learning how to balance a checkbook, but nobody ever taught us how do you actually advocate for yourself in a healthcare encounter. What are the things you need to ask for? What are the things you need to keep track of? How do you manage your own health information and so forth? That's never taught, and I wish that was, because it is absolutely a skill to build in terms of advocating for yourself. And making sure you know what questions to ask and how to present certain information and so forth.
Yeah, there's so much. Like, I feel like we are in the golden age of medicine. Maybe I'm a little bit biased, but I feel like that we can help people with things now that we were never able to help them with in the past.
Right.
But now the block seems to be this bucket of money that's over here, and we're all trying to fish into that same bucket of money and take out our little bit of it. And I know that part of this administration's movement is to shrink the ability, make it even more difficult to get access to that bucket of money.
Yeah.
Has that happened to you in your research? Has this been happening?
In terms of, particularly with regards to doing the research, yes. So this administration has definitely enacted a number of rules and trying to essentially shut down the research overall. I and many others have had the experience of having our grants terminated in terms of any research around trans issues was deemed unscientific or not contributing to the general well-being of the populace. That was very frustrating. And despite knowing that that was coming, it was still a major setback for the work that we do in terms of having to put a lot of projects on pause, having to find ways to have my salary paid for, having my staff's salary paid for it. I resolved to not have it. I wasn't going to fire anybody because the government said no for our funding.
Thank you.
So it was really a very stressful few months last year. And then I and others, we sued to get our money back. And it took many more months to get it back, and we did, and we're doing that work. But we can't trust the NIH to fund future work on trans-specific stuff right now. So we are trying to find other ways of doing that through foundations and what have you, other pots of money. But none of them are as big as the NIH. The NIH, I think people underestimate how significant the National Institutes of Health have been for decades in advancing biomedical research globally. And it's only been in the last 15, 20 years where anything LGBTQ related was actually funded by the NIH specifically. And that was because of a lot of advocacy, a lot of groundwork, a lot of small studies demonstrating the need for larger studies. This major setback right now is going to slow us down for decades for everybody across the board, not just my own work. So yes, we are being made. The pot of money has either stayed the same or shrunk a little bit, and we are being told that we're not allowed to access it anymore, and that's just going to cause a lot of issues.
And I know that you just recently had an article published in the New England Journal of Medicine about this very topic.
Yeah, what I felt when I first had the grants terminated and I saw their notice of this isn't contributing to anybody, I feel like the research obviously is going to directly impact the well-being of trans folks, but I think we as scientists are not taught to be good communicators, and we're not taught to really recognize how is the research question in front of us maybe going to expand and affect everybody. And I used this opportunity, ruminated on this for a while, and talked to a lot of folks about how broadly LGBTQ health research has the potential to impact everyone and has impacted everyone. A lot of our research to understand how the dangers of loneliness and isolation are actually from studying LGBTQ youth. A lot of our questions around hormones in general, we've actually learned a lot from studying the well-being of trans folks and their experience of hormone therapy and so forth. There's so many components around sex and gender that we've understood by studying trans folks that actually impacts the well-being of cisgender folks. And I think we have not communicated that effectively enough. And I tried getting that as briefly as I could within this New England Journal of Medicine article about how the tools we have now are going to continue to not serve not only trans people well, but aren't going to serve certain groups of cisgender people well without the research. And so that's what we tried to really put out, is this notion that if you're attacking a small population, you're actually going to be affecting the entire population.
And doesn't that happen with research quite often? What does this medicine do to impact this?
Yeah.
And then all of a sudden, oh my God, look what it just did over here.
I mean, so much research is supposed to really be driven by curiosity. What are we noticing in the world? What do other experts think may be happening? I think there was actually a great New York Times article that talked about the notion of the GLP-1 medications that we use for treating diabetes and weight loss and any number of things now. The understanding of that really started first from just some guy looking at certain hormones and peptides in lizards. Didn't know what that peptide was going to do in the human population, but that early research was fundamental in defining what could be done with it later on. At my time at the University of Chicago, we learned a lot about the history of the scientists there. Understanding and defining what the electron did back in the early 1900s, nobody knew what it meant in terms of actually then utilizing that research to do any number of studies around electromagnetism and so forth. But those primary studies needed to be supported for us to even be able to begin to understand what's going on later on. So this is one of those situations where politicians need to prioritize science and then get out of the way. They shouldn't be the ones deciding what the research questions are. That should be the scientists, the experts, the communities that are being studied with, and so forth.
And that makes sense.
Yeah.
It seems so simple, doesn't it?
It seems so simple, and we had been doing a decent job of it. I mean, arguably, The NIH was designed to be meritocratic. There are many flaws to it. That's just the nature of anything made by humans. There's always going to be some flaws. But it aspired to be focused on, we want the best research questions that have the best potential to be successful, to move the needle on whatever we're looking at.
And so you were saying that this research has been delayed for possibly decades now, or stalled for decades.
Yeah.
I remember that in the 90s, I affirmed my authentic self. Societal pressure became so much on me that I actually put a pause to my transition, and I detransitioned.
Yeah.
And it was miserable. It was like absolutely miserable because I was pleasing society by harming myself more.
Yeah.
And then I affirmed my authentic self again, and I tell my doctors, so there was this starting the hormones, stopping them, and starting them again. What did that do to my body? And they're like, we don't know.
We still don't even have a good answer for that because, again, one, research now has been stalled. There's been a number of studies that were trying to define that, to find the right number of people and to accurately define this period of time when you're like, okay, started hormones, off hormones, and so forth. How do we measure that accurately? Yeah, we have a major setback. And this is one of those things where we look to our colleagues in Northern Europe where they have wonderful data sources and their government has not gotten in the way of them at least doing the research. They're going to be ahead of us in terms of providing guidance. And I'm like, that's fine. We'll learn from them. We will, when we have the chance, we'll try to replicate it here in the US because that's what a lot of science is replication and redundancy to verify the facts. But repeatable. Exactly. But unfortunately, the US will not be the leader in biomedical research like it has been for decades.
And is that another reason that we're losing healthcare professionals, do you think?
We definitely have a brain drain. Actually, a colleague, wonderful early career, mid-career researcher has just moved to Amsterdam because they could no longer do the work where they were in the US. I've had a number of people who are no longer doing trans-related research because they got a mortgage and I understand they need to pay their bills and so forth, and therefore they need to focus on what's going to pay the bills. And unfortunately, the government is not allowing trans research to be one of those things.
And I feel like with me pausing for that length of period, there has to be times when cisgender women stop making hormones for some reason, cancer or something, and then it gets kicked back in again. So that information would help.
It would absolutely help them. And even in, those are rare instances that you're describing, but there are definitely situations where cisgender women are experiencing early menopause at an earlier age than would be expected. Cancer treatment being one of those, any number of conditions that are affecting their ovaries. And we do know from having decades of research that those women experience worse cardiovascular outcomes than if their menopause was later in life. And understanding that has actually tried to inform some of the work that we do in trans healthcare, but we're also trying to use the experience of trans healthcare to understand what's going on for those cisgender women. Because all the tools we have, they don't actually accurately describe the experience of cisgender women with early menopause well. So you're absolutely right. There's much to be learned from each other on that.
We're all human, aren't we?
We're all human. We all have unique trajectories. I think as a scientist, being able to understand and define those trajectories will help inform the best interventions for everyone.
And this is a pie in the sky hope.
Yep.
If you had your way, what would your research look like?
Oh goodness. I have this question often. I wish I had an endowed chair. That way I didn't have to worry about the political pressure of grants. but if I had that, I would have a dedicated community advisory board of transgender folks with different experiences, and we'd be querying them. Okay, what's important to you day to day? What's important to you for your health? Okay, let's distill this down to a research question and then go answer it. That would be what I'd really want to do, in terms of not having to necessarily chase what an institution's willing to fund, but be like, this is what the community really wants answers for. And that's actually happened through a few grants, but not as many as I would like. And then we'd be focusing on recruiting a longitudinal cohort of trans people from early age through the rest of their life, and we would be defining all of these different health outcomes that are important to the community. Cardiovascular health, thankfully, is a community-focused question. It's not just one that I grabbed onto and made up off the top of my head, but that and many other conditions would be things we would track long-term. And it would ideally be a cohort, not dissimilar from the Framingham Heart Study that we follow for decades. And then we bring in the next generation and we follow them for decades. That's what I would dream for, is a massive longitudinal cohort in the U.S.
Fingers crossed we get there for you.
Yeah.
I think that one of the things I'd like to wrap up with is, I don't, when we're talking about me being transgender, people picture a transgender person as you come out of the womb, you're 3 years old, and you start hormones, or you start puberty blockers, or you immediately, this happened. For me, it was the first 25 years of my life, there was no affirming my authentic self other than secretly, because I was terrified of my family and society and my church and all the other things, the repercussions of that happening. So I affirmed my authentic self when I was 25 or so, but there was this decades-long not an intervention medically whatsoever. Now I'm a trans athlete. I was an athlete before, but I was still a trans athlete even before I affirmed my authentic self. And I think people forget that just because I did not affirm my authentic self doesn't mean that I did not see myself as a woman that whole time. I just didn't have the ability. So I started the estrogen. I'm a professional disc golfer. I'm the first openly transgender woman to ever register and sign up for the Professional Disc Golf Association. And they had this huge guideline. You have to meet this. A lot of gatekeeping took place. A lot of hurdles were in place for me to play in the women's division. And they were okay with it. The Olympics were okay with it. There must have been research done at some point to show that I did not have a competitive advantage, because I get my butt handed to me by women all the time that aren't trans. Like I just went and competed against one of the best women disc golfers ever, and I almost beat her, but I didn't. Does that mean that she's trans because I couldn't beat her? So that research that took place in the past is still there, I'm assuming. Is that correct? And or it must be minuscule, but there had to have been some research for the IOC and things like that.
There was some research around strength and muscle performance based strictly on testosterone levels. But this is the thing, the question of sports, I think, is much trickier than people would like it to be. And at the end of the day, research needs to be focused on the specific performance that's being questioned. Running is not the same as swimming, is not the same as gymnastics and so forth. Each of them have different physical performance metrics, have different advantage and disadvantage based on body composition and height and muscle mass and so forth, that require specific research studies to look at all of that to understand what is the benefit or not of certain medical or surgical interventions for anybody, cis or trans, and then defining that. I think there's always this big tension with sports overall of, we want sports to be fair, and I think we're still trying to define what does it mean to be fair in sports, because you can have a men's division and have two cisgender guys be a foot difference, and you're saying that they're going to have the same performance, which we know is not true. But then you want to make sure there's participation, that there's open participation. Participating in sports at any age is great for people's health. It's great for community engagement. It's great for learning how to be an independent, autonomous, self-advocating person. I think when we start getting way into competitive sports, this is where we really need the science to be allowed to speak. And this is where we need the professional sports associations to listen to the science and define what's important for them, and not have an overarching blanket policy, which we know harms many people, including cisgender women. We know, for example, the IOC already is having to perform a number of invasive studies and exams on cisgender women just for the sake of proving, are you actually a woman? And that serves nobody's benefit, and it's only going to harm women entering sports.
And I bet you they're going to find out that there's all kinds of disparity in...
Also, they have. I mean, they've already actually found by their definitions a number of women, born, raised women, have certain conditions that may be arguably defined as differences in sex development that were unknown before in these invasive exams. So, and did they have an advantage or not in the sport? More than likely not, if there was never a question before.
If sports were fair, everybody would end up in a tie.
Well, there is that. There is the Harrison Bergeron effect. If we were truly being fair, everybody would be the same performance level. I always say if sports were always fair, you would only ever be competing against yourself, because everybody's different, has a different composition, different metrics and so forth, and you would be the only competitor for your sport.
That would be boring.
It would be
That's
boring.
one of the reasons I enjoy, like I play women's disc golf here in New England.
Yep.
Fully embraced by the community.
Awesome.
Like they love me being there. And I have a sneaky feeling that if I was not a good person, like if I was, you know, if I was
Not
not
a good sports person.
a
Yep.
good sports
Yeah.
person, they wouldn't like me. And it wouldn't have anything to do with me being trans. It would be because like, ugh,
Yeah.
you're kind of like not a good person. And I think that people forget that community part of sports is
Absolutely.
also part of that health care
Very much so.
that takes place. But I really do appreciate that you took the time to sit down with me, Dr.
Of course.
Streed. Like this has been so informative for me and hopefully for everybody out there in the audience as well. Congratulations again on having your
Thank you.
article published.
Yep.
I'm sorry that you had to do that. I wish that, you know, here's the bucket of money, go do the research
Right.
because it's needed. And I feel like that the work that you're doing, obviously it saves lives. I mean, that's your goal is to help people live their healthiest, best lives.
Right.
And so thank you for that, because without healthcare professionals, we would just all be out there winging it, listening to folk medicine. And there is certainly some good folk medicine
Yes.
out there. Like
Yep.
being from the South, being from the mountains and the hollers of East Tennessee,
Yep.
I understand that some folk medicine works.
Yeah. I mean, that's where we got aspirin, bark of a willow tree. So we're always learning. But I appreciate you having me here. I appreciate you helping get the message out.
Okay, thank you so much. And everybody out there, just remember to go be kind and do good in the world. That's all that, just do that, please. Bye.